Yes. Thank you so much, Dr. Cook, for that excellent introductory talk. I'm going to be looking specifically at an approach to malabsorption syndromes. It's quite an extensive topic, and if we were to cover every other condition that could give you malabsorption, we'll be here until December, I think. So try and simplify it as best as I can. So I just need to find my cursor. Okay, so we're going to look at the definitions, briefly look at the pathophysiology, but mainly I want to focus on the clinical approach. There are some few cases that we can look at if time persists, and basically just a brief summary on how to go about it. So in terms of what is malabsorption, so basically it's conditions that arise from abnormalities in your digestion, as well as absorption of nutrients during their passage through the GI tract. And it can result from defects in any of the three phases of digestion as well as absorption. So you can have defects in your intraluminal hydrolysis of your nutrients. You can have defects in your mucosal absorption, as well as vascular and lymphatic defects that will then affect the transport of nutrients. Some of these disorders are more generalized and they affect the absorption of many nutrients, vitamins, and minerals, but some of them are more selective and involve specific nutrients. So in order for you to absorb nutrients, there are three phases. So you get the first luminal phase, which involves mechanical mixing and digestive enzymes. Then you get the mucosal phase, which basically requires a properly functioning mucosal membrane for the absorption. Then you get the post-absorptive phase, which is then facilitated by an intact blood supply as well as the lymphatic system. So then malabsorption syndromes are then categorized according to which of these three stages is or are affected. Besides intestinal disease, as well as disorders or diseases of the pancreas and the lymphatics, don't forget diseases of the liver as well as the biliary system that could also lead to malabsorption. And these conditions include cholestatic liver disease, cirrhosis, portal hypertension, as well as inborn errors of bile acid synthesis. As Dr. Cook has alluded, so appropriate weight gain and linear growth in a setting of adequate caloric intake remains the best indicator of a proper digestive function in our pediatric population. So this next few slides, I just wanted to illustrate how extensive the list of conditions is. So you can look at lipid malabsorption, things like cystic fibrosis, your Shachman diamond, all the way to diseases of your amino acid, as well as if we look at the function of the enterocyte itself. So you're having conditions like your microvillus inclusion disorders, your tufting enteropathies, and you can even have issues of vitamin and mineral deficiencies as well, leading to malabsorption. So I tried to give a simplified list to give an initial approach. Before we go to that simplified list, but also don't forget that most of the drugs that we use, as well as supplements, they can also lead to nutrient malabsorption. An example of this is azathioprine, which we use for our autoimmune conditions. It can lead to generalized malabsorption as well as villus atrophy, as well as glucocorticoids. They do inhibit calcium absorption. And a drug like phenytoin, it does cause inhibition of folate and calcium absorption, as well as impairment of your vitamin D metabolism. And we do know that PPIs are associated with small intestinal bacterial overgrowth. So if you, as a starting point, so you can look at pancreatic causes, and the common one that we all know of is cystic fibrosis, any conditions that will lead to chronic pancreatitis, Shachman-Diamond syndrome, Pearson syndrome, and conditions that will lead to bile acid deficiency, like chronic cholestasis, if a patient has had ileal resection, and then looking at the intestinal lumen, so your brush border disorders. So this could either be, it's a congenital anomaly or congenital causes, like your primary lactase deficiency, your microvillus inclusion disorders, or it could be as a result of an inflammatory cause, like celiac disease or inflammatory bowel disease or your allergic enteropathies. Or it could be as a result of the fact that now you've reduced your mucosal absorptive surface. So conditions like short bowel syndrome, as well as patients that have had their ileum resected for various reasons, either be necrotizing enterocolitis or they've had Crohn's disease. So in terms of short bowel syndrome itself, don't forget your congenital malformations, so like your gastroschisis, your small intestinal atresia, as well as necrotizing enterocolitis. And older children can have short bowel syndrome as a result if they've had sustained abdominal trauma that resulted in extensive bowel reception. But also, don't forget your kids in your oncology units that will then suffer from radiation enteropathy. So if you were to go through the clinical approach, so features of malabsorption are very variable, and they basically depend on what is the etiology as well as the extent of the gastrointestinal defect, the age of presentation, and whether there are any comorbidities that are associated. So when you evaluate a child with malabsorption, you need to basically confirm the presence of malabsorption, identify the cause, treat the underlying condition, and don't forget the nutritional deficiencies. And most of these patients will normally present with the nutritional deficiencies first that will then tend to prompt you to looking for a malabsorption syndrome. So the cardinal or the core clinical presenting symptoms will be a patient that presents with ongoing or chronic diarrhea. They have unintentional weight loss despite normal nutritional intake, or they have very greasy, foul-smelling stool that they're unable to flush. So additionally, they could also have complaint of flatulence or bloating. And abdominal pain, it could be a presenting symptom, but it's less common in most of the malabsorption syndromes. So basically your symptoms or signs is either secondary to the malabsorbed material in the GI tract, or it's related to the specific nutrient deficiency. And how you can look at this, you can divide it into, is it gastrointestinal or it's extra gastrointestinal manifestations. So if you were to look at the gastrointestinal manifestations, diarrhea is the most common symptom in malabsorptive syndromes. And there's a lot that you can basically learn or from a stool sample. As I always say, the currency in gastroenterology is stool. So if you're suspecting a carbohydrate malabsorption, so usually your stool is explosive, watery. It can cause skin irritation and erythema in the perianal area because the stools are usually acidic. So if it's bulky and greasy and foul smelling, then you know you going along the lines of pancreatic insufficiency. And if it's nocturnal diarrhea or the diarrhea that does not respond to fasting, it points you towards the secretory diarrheal conditions. And if there's blood, you think of like an inflammatory process, and this could either be inflammatory bowel disease or is an eosinophilic enterocolitis. And also, if you see things like loose stool with undigested food particles, and this is normally seen in toddlers' diarrhea, and it's not usually a sign of malabsorption. Other GIT manifestations could be abdominal distension, and this is as a result of bacterial fermentation of your malabsorbed carbohydrates in your colon as well as your small intestine. And then you can also have abdominal pain. And then if you have edema of the legs, puffiness, and ascites, also think of an associated protein loss or protein malabsorption. So looking at the extraintestinal symptoms and signs, failure to thrive or growth faltering is as a result of your secondary nutrients that are being malabsorbed. Things like anorexia and food refusal could point you towards an underlying mucosal inflammation, and obviously bleeding tendencies, you will be looking at vitamin K deficiency. Don't forget your neurological symptoms, things like ataxia, which you will see in vitamin E, vitamin B12 or folate deficiency. And we all know the clinical features of vitamin D deficiency, and skin with your ectodermatitis for zinc deficiency as well could be a useful clue. So what are your useful clues in your history? So a detailed, thorough dietary history is your starting point. And you need to ask about how the parent or the mother dilutes the formula, if there's any high intake of fructose or sorbitol, and try to work out if there is any evidence of inadequate caloric intake. And also try to establish the relation of the symptoms to the newly introduced food. And this usually applies for conditions like your allergic enteropathies. Ask about if there's been any previous gastrointestinal surgeries, entertaining the diagnosis of your short bowel syndrome, if there's been any history of cardiac surgery, which becomes important if you're looking at lymphangiectasia, and extraintestinal symptoms that could suggest inflammatory bowel disease, as some of our patients normally will present to a rheumatologist because of arthritis or joint pain, or an ophthalmologist because of a uveitis, or even a dermatologist because probably they have this massive ulcer, pyoderma gangrenosum, and then looking back or going backwards, then obviously it can help you, and then you can make the diagnosis of inflammatory bowel disease. So what would be your diagnostic approach? Like I said, you need to carefully assess all your presenting symptoms. Don't forget neurological entities, as most of our nutritional deficiencies will have neurological symptoms, and also systemic presentation, not just only GIT manifestations. And what is also important is that many of the non-digestive disorders, such as a UTI, can present with features of malabsorption or maldigestion. And your malnutrition states that results from maldigestion and malabsorption often present with apparently unrelated complaints, such as bleeding, easy bruising, or rashes that could be as a result of nutritional deficiencies. And particular attention should be paid to a possible dietary manipulations that are done in an attempt for them to manage or decrease these symptoms. So find out from the mother, so what have they done to basically try and improve the diarrhea, like your home remedies, and also what has been the effect of them introducing new foods to the diet of the child, which can actually help you towards your allergic conditions like FPIs, for example. So, and I'm just going to go through, so what does your assessment of this patient comprise of? So Dr. Cook has spoken about anthropometry. What I want to highlight is that don't forget that to assess your skin fold thickness, as well as mid-upper arm circumference, and these are actually available in you assessing muscle mass as well as fat stores. And vital signs can also give you subtle clues. Like bradycardia can be an adaptive response to chronic malnutrition, and tachycardia could be the way that the patient will present as a sign of chronic anemia. So this slide is meant to illustrate that there's certain things in your growth chart that could actually help you try to figure out if it's a digestive disease that's causing the growth faltering, if it's endocrine, or if it's a neurological etiology. So if you look at the neurological etiology, you will see that if you look at the patient's head circumference, the weight, as well as the length, all of those parameters basically below the third percentile. But if you look at an endocrine etiology, you will notice that most of the patients, your head circumference will be preserved, growing above the 50th percentile, but mainly the length will be much more affected compared to the weight. And then if it's a digestive disease that's causing the malnutrition, it's mainly your weight that is much more affected compared to your length or your height. Don't ever forget the skin, as there's a lot of clues that you can get from the dermatological manifestations, especially when you're looking at your vitamin deficiencies. So where do we start investigating these patients? So you can start off with some screening tests, and these tests include blood tests as well as stool tests. So if you're looking at blood tests, so there's certain things that could give you subtle clues. Like if your patient has lymphopenia on the background of diarrhea or failure to thrive, you can look at conditions that, for example, a lymphangiectasia. And if they have a peripheral eosinophilia, then you know that you're looking at your allergic enteropathies. Acanthocytes are present in patients that have A beta lipoproteinemia, and increase in your platelet count is normally associated with your inflammatory diseases. Other things that could help is basically looking at your serum protein as well as albumin. And this will sort of like indicate your secondary protein loss, malabsorption, or inadequate intake. And looking at protein, it has been noted that prealbumin is actually the best marker in acute malnutrition, and also to assess your efficacy of your nutritional therapies. And things like your C-reactive protein as well as your ESR are useful inflammatory markers when you're looking at an inflammatory kind of etiology. Then coming to the stool test. So like I said, there's a lot of clues you can get from the stool test. So for carbohydrate malabsorption, we know that you're looking at an acidic stool pH. Reducing substances will indicate your carbohydrate malabsorption, and your stool electrolytes in a watery stool will help you differentiate whether it is secretory or is it osmotic diarrhea. And then looking at a fecal alkyl blood as well as a fecal calprotectin in an inflammatory cause. And your fecal elastase, we normally do it in patients that you suspect that they might have an exocrine pancreatic insufficiency. So then if you're looking at more definitive stool tests, so these ones are more sensitive for fat malabsorption syndromes. So you can start off by looking at a fecal fat, and this is measured at a single stool specimen. And if this test is positive, or you have a high index of suspicion for fat malabsorption in your patient, you can then proceed to do a 72-hour fecal fat excretion. This test is a gold standard for steatorrhea. However, you need to be collecting the stool for 72 hours, which can be quite daunting. You can also do a stool steatocrit. And what has also been described in the literature is something called near-infrared reflectance analysis, which basically has comparable accuracy to your 72-hour fecal fat excretion, but it is faster, and it does also measure other things like nitrogen and carbohydrate while also measuring your fecal fat. So then looking at more specific tests, basically these tests will be conducted in a stepwise manner, starting off with sort of like your non-invasive test and moving forward to the most invasive test. And that's where most of the pediatric gastroenterologists gets involved in the management of these patients. So if you're looking at specific serological tests, you know you can do things like your endomysial or your tissue transglutaminase antibodies for celiac disease, sweat test for cystic fibrosis, and your breath test for carbohydrate malabsorption syndromes, and as well as small intestinal bacterial overgrowth. But the gold standard for small bacterial intestinal overgrowth is your jejunal aspirating culture, and this test is quite invasive. And so we'll sort of like start off with your breath test before embarking on this more invasive test. So in terms of your breath test, so you can have a lactose breath hydrogen test for lactose malabsorption. And basically a positive test is when you have an increase in your breath hydrogen concentration of greater than 20 parts per minute over baseline after ingestion. But just remember that an early increase can occur in the first 30 minutes, and this needs to be discarded because it reflects the fermentation of lactose by your oral flora. And if you suspect a fructose malabsorption, you can do fructose breath hydrogen testing as well. And then when it comes to imaging, you can have access to upper GI series with small intestinal follow-through. However, these are not routinely used as they are not really specific for malabsorption. But it is a useful technique in evaluating small bowel strictures and fistulae in patients that have Crohn's disease. The value of the CT scan in malabsorption syndromes, it's useful in selected cases to detect small intestinal lesions such as strictures or abscesses. However, the concern with CT is the irradiation risk to children, and hence there is a movement to use more of MRI because of the decreased risk of irradiation. MRCP in the setting of pancreatic exocrine insufficiency, as well as you can use MR elastography, and this is a non-invasive method to assess stiffness of an object. So we normally will use it in patients to assess liver stiffness, to diagnose fibrosis or other conditions that can increase your liver stiffness as well. And this is quite useful because your patients don't have to go through the invasive procedure of doing a liver biopsy. ERCP, it's got its limitations, especially in our pediatric population, because of the small size of the patients that we look after, as well as the limited expertise of the surgeon or the person performing the ERCP in a small child. And we also don't forget the associated risk of pancreatitis. Endoscopy and biopsy, it's useful in conditions where you need both visualization as well as tissue diagnosis. And these conditions include things like celiac, inflammatory bowel disease, and eosinophilic enteropathies. In terms of an abdominal ultrasound, it can help us detect complications like abscesses and fistulae, but also remember that the findings are usually non-specific and basically dependent on the operator and the interpretation of the person who's doing the ultrasound. EUS, it's got its role in adult GI as well as pancreatobiliary diseases. But the problem with EUS is that it's got limited usefulness in our pediatric population. And if you do have access to it, you can actually, for your lymphangiectasia, you can do a radio-labeled technetium albumin lymphatic scan. So then looking specifically at endoscopy as well as histology. So there's certain conditions that by you doing an endoscopy and in histology, you can sort of like get to the diagnosis. So there's specific endoscopic findings that you can see with specific conditions. So if you look at celiac disease, the typical endoscopical finding, you can see villus blunting. And on histology, you can appreciate that you can see the blunting of the villi as well as the crypt hyperplasia. And there's the increase in your intraepithelial lymphocyte that the histopathologist normally comments on. And then when it comes to eosinophilic esophagitis, there's typical endoscopic features, which basically includes furrowing or whitish exudates, which are filled with eosinophils. You can get the trachealization look of the esophagus. And then obviously with progression of disease, then you start getting stricturing and narrowing down of your esophagus. And on histology, you can appreciate the increased eosinophils that are noted in the esophageal mucosa, and there needs to be more than 15 per high power field to be significant. And then for Crohn's disease, I just put up this histological slide just to appreciate the inflammation as well as the granuloma that will normally come as part of a histological report. So this is a non-caseating granuloma that is normally associated with Crohn's disease. And then this is a slide showing intestinal or duodenal mucosa of a patient with suspected A-beta-lipoproteinemia. So you can see basically the fat deposition that you can appreciate on the slide. So lymphangiectasia, you can also on endoscopy. So what you will normally see, you will see this whitish dilated swollen villi. And on histology, you will see the dilated lymphatic vessels. And obviously in an infectious etiology, your histological examination can pick up Giardia as well as Mycobacterium and infections. So when it comes to treatment of these patients, treatment basically involves treating or correcting the deficiency that they have. You treat the underlying cause, you avoid the trigger, and you treat the symptom. And in most cases, the symptom is diarrhea. So in summary, before we quickly look at the clinical cases, if you don't take anything from this talk, I think if you can just focus on this last 3 slides. Basically, is the most presenting symptom we know it's diarrhea. So if you approach your patient as they've had chronic diarrhea for more than 4 weeks, you ask yourself, are there any red flags? So the red flags will basically include a neonate, if there's blood, mucus, or fat, or nocturnal diarrhea. If a patient has unexplained fevers, they have growth failure or developmental delay, they have other extraintestinal manifestations like arthritis, eye or skin involvement, and they have features of nutritional deficiencies. So if your patient has had chronic diarrhea with any of these red flags, then you proceed and you ask yourself, basically trying to figure out, is it watery diarrhea, is it inflammatory or bloody, or is it fatty, and we'll proceed thereafter. If your patient doesn't really have any red flags, then you need to look at something like is it irritable bowel syndrome, is it functional diarrhea, or is it toddler's diarrhea? So if it is watery diarrhea, then if your patient has associated edema or they have a lymphopenia, a condition to exclude or to entertain is to make sure that you're not dealing with protein-losing enteropathy or as well as intestinal lymphangiectasia. If your patient just has watery diarrhea, try and see if they respond to a fasting trial. And if they respond to a fasting trial and their fecal osmolar gap is more than 100 and their stool pH is acidic, it points you more towards your osmotic diarrhea. But if there is minimal or no improvement in your fasting trial, your stool osmolar gap is less than 50 and your stool pH is normal, you're looking at your secretory diarrheal causes. And then with that, you can then look at the age of onset. So if it's secretory diarrhea and the age of onset is around newborn or infancy, then you're looking at your congenital secretory diarrhea. You're looking at conditions like microvillus inclusion. You're looking at your tufting enteropathies. And that's where further investigation, including imaging as well as endoscopy and biopsy and genetics, will help you basically come to your diagnosis. And if your diarrhea is bloody or inflammatory, you need to first rule out an infection. And then you look at the age of onset. In an older child, things to consider will be inflammatory bowel disease or your allergic enteropathies. And in a newborn or in a smaller baby, also consider cow's milk protein allergy. And then if it's not cow's milk protein allergy and it doesn't basically improve with you changing your formula, then you need to consider conditions like very early onset IBD or a primary immune deficiency disease. And then if your diarrhea is fatty and they have edema or hyperalbuminemia, you go along the lines of a lymphangiectasia or a lymphatic disorder. And if you have presence of fecal fat or fat globules in your stool and your fecal elastase is abnormal, we go along the lines of your pancreatic insufficiency. There you're looking at things like cystic fibrosis, Schachmann diamond, or chronic pancreatitis. But if you have normal elastase, but you have abnormalities in your cholestatic liver enzyme, then you need to evaluate for cholestatic liver disease. So basically, in summary, just always remember that treatment of these conditions could be as conservative as dietary changes, such as you avoiding the offending food group or supplementation, but it could also be as invasive as these patients requiring transplant or requiring surgery. In the last 5 to 10 minutes, I think we can just quickly go through these quick short cases. The reason I chose this case is I just wanted to illustrate that the diagnosis can be glaring, it can be simple, you can get to the diagnosis quick and fast, but sometimes it can take some time to get to the diagnosis, and then it requires a multidisciplinary approach, and a lot of invasive investigations can be done for these patients. So the first child, I just made it very brief and I quoted the abnormal investigations only. So we've got a 10-week-old that presented with failure to thrive. Birth weight was 2.8 kilograms. And when they presented at 10 weeks, the current weight was 2.6 kilograms, and they were noted to have generalized edema. On admission, the child was presumed to have sepsis with a pancytopenia and had a symptomatic anemia, which led to congestive cardiac failure, and hence the patient needed ICU admission. So the problem list was newly diagnosed HIV with a pancytopenia, and this child also had CMV hepatitis. So was the pancytopenia as a consequence of sepsis, or was it as a result of the congenital infection being CMV, being HIV? And the failure to thrive with generalized body swelling, we were dealing with a child that has congenital AIDS, or did we need to look a bit further to find the diagnosis? So basically the summary of the workup was what was significant was that the fecal elastase was was less than 15, and that prompted us to basically do a sweat test. However, the child was quite small and we were unable to sweat on multiple attempts. We then basically did the genetics, and it confirms the diagnosis of cystic fibrosis. So this one wasn't a very long road to get to the diagnosis. Then you come to the second patient. So this child was a 6-month-old that presented with chronic diarrhea since 2 months of age. The patient was term, 3.8 kilograms. And when they presented at 6 months, they were noted to be 3 kilograms. On examination, they had normal hydration. However, they had this bilateral lower limb edema, as well as abdominal distension. There was a background of reflux on and off, getting better with the PPI. However, this child was not improving in terms of weight gain. So summary of the stool test. So microscopic culture and sensitivity was negative. Fecal fat was noted to be present, and the fecal alpha-1 antitrypsin was noted to be elevated. Other blood or investigations of significance was this patient had a lymphopenia, noted to have hypoalbuminemia, as well as hypogammaglobulinemia. I don't know if anyone can tell me what the diagnosis is or what's a possible consideration. They can put it in the chat. But for the sake of time, I'm just going to move on. So we then did endoscopy on this patient. And this is an image of the duodenum. So you can see that from this picture, the swollen or the swelling of the villi. And then on the histology, you can see the dilated lymphatics. So this patient was then diagnosed with intestinal lymphangiectasia, and other investigations that you can do to confirm the diagnosis. You can actually do a capsule endoscopy, or you can actually do MR lymphangiography or a whole body MRI. So treatment of your intestinal lymphangiectasia, basically first line therapy is mainly dietary. So the mainstay treatment of primary lymphangiectasia is dietary. And dietary basically includes high protein diet and a low fat diet. So your fat should basically include more than 90% being medium chain as well as short chain triglycerides, because these get directly absorbed through the portal circulation and they don't require the lymphatic system for absorption. This then basically decreases your intestinal lymphatic flow. But it can be very difficult for the patient to maintain this diet for a very long time. Hence, you can consider your second line therapies. So if it's focal intestinal lymphangiectasia, you can do surgery, or basically you can start this patients on octreotide. So octreotide is your somatostatin analog. It decreases your splenic blood flow, intestinal motility, as well as triglyceride absorption. And the dose that we normally give is 1 to 10 mics per kg with dose subcut twice a day for a period of 2 weeks as induction therapy. And then your maintenance is basically the same dose injected at 4-week intervals. Other modalities you can use is sirolimus, as well as propranolol and tranexamic acid. I don't have a picture of this child, but after we started our patient on subcut octreotide, we had very good weight gain, and the patient is being followed up at George Hospital. And then the last patient. So this is a term baby that was born at 40 weeks, but with a low birth weight of 2.2 kgs and IUGR. It was a very long, stormy course, but at 3 months, this patient presented with abdominal distension and septic shock to the referring hospital and was diagnosed with NEC, had a laparotomy, and multiple gangrenous lesions were noted all over the length of the small bowel. Subsequent to that, this patient had chronic diarrhea. There was no bowel resection that was done. Basically, they just resected or biopsied those gangrenous lesions. This patient suffered from chronic diarrhea with severe failure to thrive. And when the patient was admitted to our unit at 4 months, the weight was 2.6 kilograms, and this child was plotting below the -3 Z-score for weight for age. There had been a trial of multiple feeding formulas at the base hospital. This patient had been on an extensive multiple formulas, which included an anti-reflux formula, prenin, alfarin, neocate, and TPN, and with no improvement in the weight as well as the clinical status of the child. Just some of the relevant investigations was that your fecal osmolar gap and your reducing substances were negative. Your fecal alpha-1 antitrypsin was negative. Fecal fat histology was negative. Fecal elastase was good, more than 500, so there was no pancreatic insufficiency. There was no cystic fibrosis, as the sweat test was normal, and the CF genetics were also negative. So after multiple months of being in our ward, while we were trying to maintain weight gain on our patient by using an extensively hydrolyzed formula, which was alfarec, we eventually gained weight to 2.8 kilograms. However, we could not explain why this patient was failing to thrive at the beginning. So this patient had a challenge. Basically was given, sorry, it's not supposed to say alfarec, that's a typo. This patient was basically given infotrini, and after being given infotrini, then developed vomiting and diarrhea within 1 hour with severe metabolic acidosis requiring an overnight stay in ICU. And then once we got the patient stable, out of ICU, out of shock, then the diagnosis became very clear to us. So this patient was suffering from chronic FPIES and was subsequently started on neocate and gained weight and actually was admitted in our units from Feb of 2024 and only got discharged around August of this year. So where we are with this patient at this point in time, we are doing slow, gradual introduction to other food groups. So we are still on neocates, but it's been a slow, gradual introduction to like maize porridge, then eventually potato, chicken, beef. And recently, in this last admission 2 weeks ago, we introduced peanut butter. And we are going to admit, because we are now doing in-hospital food challenges, so we're going to try egg and fish. So remember, when we first met the index patient, we were weighing 2.6 kilograms, and at 1 year, actually turned 2 weeks ago, we are now weighing 7 kilograms, and we are now on the -2 Z-score. So what I just wanted to highlight is what's the diagnostic criteria for acute FPIES as well as chronic FPIES. So for acute FPIES, you need to, for you to make a diagnosis, you need a major criteria plus or minus 3 minor criteria. So your major criteria is vomiting 1 to 4 hours after ingesting the food trigger. And your minor criteria basically include things like 2 or more repetitive episodes of vomiting, extreme lethargy, need for you to be admitted in an emergency department, diarrhea within 24 hours, hypotension, and hypothermia. And for chronic FPIES, the most important criterion for the diagnosis is resolution of symptoms within days of eliminating the offending food and acute recurrence of symptoms when the food is being reintroduced. And these symptoms are vomiting within 1 to 4 hours and diarrhea within 24 hours. You can have a milder presentation, and you can also have a very severe presentation. So also just remember, as part of your differential diagnosis to consider in FPIES, also make sure that you've excluded an infectious etiology. Is it not NEC, as well as your allergic or immunological conditions like your IgE-mediated food allergies, primary immunodeficiency, inflammatory bowel disease, celiac disease, and other things like your metabolic mitochondrial disorders, your fructose intolerance, as well as food aversion. And just remember also, there is cross reactivity in FPIES. So if your patient is reactive to soy, the risk of them reacting to cow's milk is about 40%. And if they are reacting to cow's milk, the risk of them reacting to soy is about 37%. And the list goes on according to, as you can see on the screen there. I just want to add by this picture. This is our patient. So if you can see, this is when they first presented at their base hospital, where they were diagnosed with NSC and needed a laparotomy. And the picture on the far right was taken about 2 weeks ago on her first birthday. These were my references, and thank you so much.